Good morning, everyone. I think maybe we'll start off and let others join as they'll come in. Welcome, everyone, and thank you for joining today's webinar, Building Resilient Health Systems in Fragile Contexts to Prevent and Treat Malnutrition. In this session, we'll be looking at lessons learned and the case in particular for multi-year funding in nutrition programming. My name is Kate Golden. I'm Senior Nutrition Advisor with Concern Worldwide, and it's my pleasure to moderate today's discussion with an excellent panel of very experienced nutrition experts. Before we begin, I have, of course, a few housekeeping notes. First, I'd like to draw your attention to the instructions that you will see on your screen in just 1 second. Gillian, can you advance? There we are. On how to access our interpreters, Cindy and Sally, who are live with us. We will hear from 5 speakers today. Our first 3 speakers, Amina, Barbara, and Helena, and our final speaker, Patrick, will all present in English. So you can hear the French interpretation of their presentations by using this function. Hopefully everyone can see that there. And our 4th speaker, Mado, will present in French. So you can turn on the interpretation function to hear the English interpretation, but Mado's slides will actually be in English, but she'll be speaking in French. The second point is that the chat function will be turned off during the presentations to minimize distraction. And the third is that for the Q&A answer session at the end, we will prioritize the questions that have been submitted to us via the registration for the webinar. So hopefully you had a chance to drop your questions in there. However, you may also submit a question via the chat function, which we will turn back on for the Q&A session. And if we have time, we'll pose those to the speakers as well. In a few minutes, I will introduce you to our speakers. But first, I'm going to try to set the scene a little bit by framing some of the whys and the whats around today's topic. And the rest of our session will hopefully focus more on the how. Specifically, why is health system strengthening so important to preventing and treating malnutrition at scale in fragile contexts? What is a shock responsive health system and why is it important? And why do we need to somewhat rethink the funding models used to support this work? Before that, however, I'll start with the fundamental why, which is why is this important? And I won't rehash the statistics here too much, as I'm sure most of you are very familiar with them, especially in these weeks leading up to the N4G. And you would almost definitely already agree that there are still an unacceptably large number of malnourished children in the world today, despite progress over the last decades. UNICEF, WHO, and the World Bank estimate that roughly 145 million children are still stunted, 45 million are wasted, and of those, about 1/3 are severely wasted. And to date, UNICEF also estimates that only 1 in 3 of those severely wasted children are accessing the treatment they need to recover and to survive and to hopefully thrive. From these figures, it is very clear that we need to do more work to prevent all forms of malnutrition. And unfortunately, we also still need to ensure wasted children have access to treatment services when they need it. Leads to my first question, why is health system strengthening so important to preventing and treating malnutrition at scale in fragile contexts? Well, first, a big piece of the malnutrition prevention work must be done via health systems, namely preventing and treating the illnesses that contribute heavily to malnutrition at both the facility and the community level. We know food systems are, of course, central to this, but the importance of the health system should not be underestimated in the fight to prevent malnutrition. Second, the treatment services that are needed to address child wasting must be delivered via the health systems. Again, I'm talking about health systems at facility and community level. Nutrition services are usually on paper part of the essential health package in most countries. In practice, however, they're not always truly integrated into the health service. This is particularly the case for treatment services for child wasting. For example, management of ready-to-use therapeutic food is often funded and managed in a somewhat parallel fashion. So in countries with a high burden of malnutrition, better integrating nutrition services into health systems, we think, is the only way to reach scale, even in fragile contexts. The government health system, however weak, is the backbone of health service delivery in any country. And we'll hear more about this from Mado Diakite shortly on Niger, who is furthering this integration at scale. The second question, what is shock responsive health system? What is a shock responsive health system and why is it important? As we know, health systems in fragile contexts such as Somalia, South Sudan, Sudan, or Chad are usually overstretched at the best of times. And just like more stable countries, these countries need coordinated, sustained efforts to strengthen the basic building blocks of the health system to ensure, for example, that health staff are present, they have the technical skills they need to deliver services, and they're being paid. And we also need to ensure that medical supply chains are functioning. Health systems in fragile contexts, however, also need to develop built-in strategies to be able to cope with the many shocks that they face on a regular basis, such as active conflict, population movements, drought, floods, and economic crises. This means health teams at facility, district, and national level need to better anticipate and prepare for those shocks. And health system resilience is a concept that is gaining more recognition. The CMAM surge approach was developed by Concern and partners to help health systems better anticipate, prepare for, and respond to seasonal peaks or surges in child wasting specifically. And Concern feels that this approach is important, and ECHO is currently supporting the continued development and scale up of the CMAM surge approach via the ERNI program, which you'll hear about in a minute from Amina and Barbara. Which brings me to the third question, why do we need to rethink the funding models used to support this work? We know that stop-start funding cycles are not efficient. They often come too late. So we really need multi-year flexible funding. And that was clearly recognized in the commitments made by stakeholders, including donors, under the 2016 Grand Bargain, which was renewed in the Grand Bargain 2.0 earlier this year. Specifically, signatories agreed to work towards a greater amount of quality funding being transferred to humanitarian partners, including a greater proportion to local actors to ensure a high quality response that is at scale, timely, and relevant. So moving on to why now, 2021 has been the Nutrition Year of Action, and today's discussion builds upon a number of important initiatives leading up to the N4G in a few weeks. There's currently a strong refocus on preventing and treating wasting. Following the Global Action Plan in 2019, we've seen the launch of the country roadmaps just this week, outlining how 23 high-burden countries will be tackling wasting in line with the Global Action Plan. The Wasting Reset Call to Action and UNICEF's No Time to Waste were also recently launched. And earlier in the year, Concern and Irish Aid hosted a 4-day conference entitled CMAM, 20 Years On, which looked at how CMAM, the community-based management of acute malnutrition, has been and can be further adapted to reach the remaining 70% of severely wasted children who are not accessing the care they need. So I invite you to read that conference report, which resonates with many of the same recommendations, and also which is available on the Concern website, and also to read the 6 excellent papers that are linked to the Wasting Reset Call to Action. And now to introduce our presenters and panelists. Today, we have a panel of expert speakers, each with unique insight and experience of working to reduce malnutrition and build the resilience of health systems. We'll first hear from Concern's Regional Director for the Horn of Africa, Amina Abdullah. Amina will speak to us about the Enhanced Responses to Nutrition Emergencies Program, which is an ambitious 3-year program that aims to reduce morbidity and mortality in children under 5. Which is being implemented by Concern across 5 countries and is supported by ECHO with multi-annual funding. Unfortunately, Leonard Mitzi from the European Commission's Department for International Partnerships, known as DG INTPA, cannot join us as planned, but we're delighted to join 2 representatives from the EU Commission. The first is Barbara Decans, who is the team leader for sectoral policies, health, nutrition, food assistance, WASH, and shelter within DG ECHO, and will speak to us about ECHO's pilot programmatic partnership with UNICEF and Concern, which is the funding stream that supports the work that Amina will describe. We will also hear from Helena Guarin, who is the head of sector of nutrition and One Health from the European Commission's Department for International Partnerships as well, who will represent her colleague Mirk Mitzi and speak about the EU Action Plan on Nutrition. Unfortunately, our fourth speaker, Dr. Osman Nassirou from the Ministry of Public Health of Niger, is also unable to attend, but we're very lucky and grateful to have Mado Tiakite, Technical Assistant to the Niger government on food and nutrition security, social protection, and the humanitarian development nexus. Thank you, Madhu, for stepping up to speak about the experience of Niger, who has been on the forefront of innovating in the field of nutrition. We're also joined by Patrick McManus from Ireland's Department of Foreign Affairs. Patrick is Deputy Director of the Policy Unit at Irish Aid. In October this year, the Irish government increased its commitment to overseas development assistance, bringing it for the first time in history to over €1 billion. Irish Aid recognizes the importance of multi-annual funding and the necessity to build flexibility across budget lines to enable humanitarian actors to respond to changing contexts. So it is my pleasure now to introduce our first speaker, Amina. Over to you, Amina.
Thank you very much, Kate. As Kate mentioned, I'm Concern's Regional Director for the Horn of Africa based in Nairobi. And I'll be speaking to you today about a major nutrition program that is being implemented in Sub-Saharan Africa by Concern. The program is called Enhanced Responses to Nutrition Emergency. And in the next 10 minutes or so, I'll be taking you through the major components of this program and discussing how such an ambitious program to strengthen health systems to deal with malnutrition in fragile and conflict-affected contexts require a longer time frame for implementation, more than the typical one-year emergency programs, projects, but also requires multi-annual funding. So I will share my screen.
We can see that, Amina.
Okay.
Just into presentation mode and you're ready to go.
Yeah, you can, it's okay. So a little bit of background on the ANI program. It is a program that's being funded under the pilot programmatic partnership by DG ECHO. It's a 3-year multi-country program that focuses on reducing malnutrition in children under 5. The budget for this program is approximately 35 million euros over 3 years, covers 5 countries, that DRC, South Sudan, Sudan, Niger, and Ethiopia.
Sorry, Amina, could you just put it into slideshow mode? I'll be able to see it a bit bigger if possible. If it's stuck there, don't worry, just go ahead.
Let me try again.
I'll jump in and share it for you, Amina. Apologies.
Please.
I'm not sure what happened there.
Please.
Just a minute.
So it should be the second slide. That's where I was at. Thank you. So it is implemented in DRC, Ethiopia, Niger, and Sudan and South Sudan. And the target is to reach 700,000 people over the 3-year period and support over 300 facilities as part of the program. Through ANI, Concern aims to increase the scale, efficiency, and effectiveness of our nutrition emergency response by working through the local service providers and communities to implement proven and innovative solutions in fragile, conflict-affected, and disaster-prone countries. It is a program that's based on the Nexus approach, as it combines life-saving primary health and nutrition treatment with cash transfers, CMOM surge, early warning system, and resilience building. Next slide, please. The principal objective of this program is to contribute to reducing malnutrition, morbidity, and mortality among children under 5, who are often the most at risk due to mortality. At risk of mortality due to significant food crisis in all the countries of operation for the program. The specific objective, as I had mentioned, is to increase the scale, efficiency, and effectiveness of nutrition emergency response, but also look at preparedness and response to food and nutrition security in the target countries. The program has 3 pillars. One pillar focuses on life-saving interventions by ensuring that quality health and nutrition services are being provided in the facilities, but also at community level using the CMOM approach. The second pillar focuses on preparedness and local capacity to respond. Again, using the CMOM surge approach. So this is looking at the capacity of the health facility to respond to increase in cases. And also looking at mechanisms that are instituted at local level or at community level to monitor changes in context that result in that surge. And based on those changes, then respond in time to ensure that the health facility or the system is not overwhelmed. The third pillar is the preventive pillar, which looks at understanding and addressing the underlying elements that make people vulnerable to undernutrition. There's a component on behavior change. There's a component of looking at infant and maternal and young child feeding practices. There's a component of WASH and other aspects of services that contribute to malnutrition. Over the course of the program, as I mentioned earlier, Concern will target 300 plus facilities in the 5 countries of operation and work with these facilities to support, but also enable them to better anticipate, prepare for, and deliver services for treatment of acute malnutrition during periods of high demands, or what we call surge. Next slide, please. Under ARNI, the resilience building for health systems and communities has 4 main components or areas of focus. One is the health system strengthening. The other area is around CMOM health surge approach. The third element is the community-based early warning systems to monitor nutrition shocks, while the fourth one is looking at community resilience building through behavior change. So I'll be speaking to each of these components as part of this presentation. Next slide, please. As I mentioned earlier, health and nutrition services under this program are being implemented through the Ministry of Health where feasible, and that is a long-term partnership between Concern and Ministry of Health in all these countries of operation. The long-term partnership, as mentioned by Kate earlier, that the context within which this program operates is one of very weak health systems, and therefore a big part of the program is around capacity building. Capacity building is not a short-term process; it's a long-term process, and therefore requires long-term engagement and long-term partnership with the entities concerned. it was therefore necessary for us to assess the capacities of these health facilities that we'll be supporting. And the assessment was done using the WHO model of health system building blocks. And the objective of this assessment was, of course, to identify and prioritize health facilities that are most in need of support to deliver effective health services, identify specific areas of weaknesses in health service delivery, but also develop tailored support plans for these facilities. And then, of course, as part of the program, measure changes in the health facility capacity over time. The health facility assessment tool and process allowed us to do an in-depth deep dive analysis into the capacity of these health facilities across the ANI countries. We therefore have taken a baseline of what capacities the health systems have, and now we'll be building these the capacity of these health facilities and monitor them over the coming two years. What the assessment showed, next slide please, is extremely high level of needs in these areas. I mean, in these countries of operation. And the needs range from poor infrastructure and sanitation to lack of adequate management of medicines and equipment, insufficient readiness and response to COVID-19, as well as lack of skills or knowledge for health workers who are managing these facilities to provide CMOM services, antenatal care, child health services, and so on. The health facility assessment does not only point out the weaknesses, but provides a set of detailed, practical priority actions to address the main gaps seen. Concern, therefore, is working with this priority action plan to build capacity of these health facilities over the next 2 years. But we are also working with other stakeholders within the areas of operation, because the action plan is quite comprehensive. And of course, as one actor, it will not be possible for us to cover all areas of gaps, and therefore looking at coordinating and collaborating with other stakeholders within the health sector in those areas. Such a deep dive analysis and ongoing monitoring would simply not be feasible in fragile conflict affected context under a 1-year time frame. Obviously, you need, the assessment itself took almost 6 months for the 185 facilities that have been done so far. So imagine if in 12 months you spend 6 months doing health facility assessments, there's very little time left to actually act on those priority action plan. But it is possible when you have a longer time frame to implement the program. Next slide, please. The next component is the CMOM surge. And as I mentioned earlier, ANI focuses on life-saving response, and central to this is, of course, CMOM, an approach that has been instrumental in, Concern has been instrumental in developing over the last 20 years. Which many of you are familiar with. Many of you are using it in your programs as nutritionists. In most recent years, an enhancement of CMOM has been developed called CMOM Surge. For those of you who are not familiar, the aim of CMOM Surge approach is to help the health systems better anticipate, prepare for and deliver services for the treatment of acute malnutrition during periods of high demand. We all know that there is seasonality to malnutrition in many of these contexts, either driven by displacement or drought or other disasters, natural disasters. It is a sustainable response to persistent malnutrition. It's an 8-step process, and this table illustrates the various steps. The steps focus on understanding the health facilities capacity and environment, and identifying simple actions that can be triggered when malnutrition caseloads increase. The approach focuses on building capacity to respond to periodic increases in caseload to ensure that the quality of care is maintained. In the alert phase, as the process has several phases, you have alert, you have serious and emergency. In the alert phase, the focus is on internal reorganization. So maybe at the facility level, you're looking at, if there was a health worker that was due to go on annual leave, maybe suspend annual leave for health workers and just have that capacity there at the health facility level. While in the serious and emergency phases, support is from the district health teams or other partners for when the situation goes beyond the capacity of the health facility and local community. Next slide, please. Globally, CMOM Surge is implemented in 17 countries with support from 17 implementing partners. And as part of ANI, Concern is leading the global CMOM Surge task force that is looking at coordination of CMOM Surge activities and driving learning to maximize the quality and effectiveness of the approach. So this is coming as part of ANI. Within the ANI program countries, CMOM Surge is being implemented at different scales because, as you know, it is an approach that has been around for a number of years. And some of these countries that Concern has picked for ANI had already initiated the CMOM Surge approach. And therefore, Ethiopia and Niger, CMOM Surge was set up or is supported across 307 health facilities. While in Sudan, South Sudan, and DRC, we are looking at a smaller scale of implementation or adapted pilots, as is the case for South Sudan. Surge is implemented at scale in Ethiopia and Niger, as I just mentioned. Since the beginning of the program, Ethiopia has been able to set up 91 Surge in 91 health facilities. And the setup has been in the Somali region. And since the setup, we have had the alert threshold breached in 2 health facilities in Somali region. Surge action plans were activated, and the actions included the redeployment of staff trained in CMOM from another unit in the health center, and increased community awareness campaigns. So we've seen how that works in Ethiopia and in other countries. A recent evaluation has also illustrated that when setting up CMOM Surge in health post, the approach needs to be simplified, considering the capacity of health extension workers, and that there's only generally one health extension worker per health post. So there has to be an adaptation. And the adaptation, again, is only possible when you have a longer time frame, as is the case in the ANI program. South Sudan is where the model is being adopted, as I had mentioned earlier, and is being piloted in one of the health facilities in Unity State. Here, the outpatient therapeutic services are separate from the main health facility. And over the last 12 months, a surge action plan was elaborated for both the health facility and the OTP. And the action plan focuses on improving communication and coordination between the 2 units. That was seen as being very important to ensure smooth delivery of nutrition services. In September, we saw the surge action plan come into use when there was a surge in caseloads due to the displacement of the population following the flooding that is currently happening in Unity State of South Sudan. Caseloads of diarrhea and malaria were particularly high, with the emergency threshold therefore being breached, and human resources and supply support was provided from the OTP as well as the district health team. So this demonstrated a perfect example of how the surge action plan comes into play, and the coordination and the improved coordination and communication between the OTP and the health facility. Next slide, please. The other component is the early warning, early action component, and this builds on concerns experiences in Somalia, Chad, Niger, and Ethiopia. The purpose of the early warning, early action is to delay or prevent negative coping strategies leading to increased malnutrition. In slow onset emergencies, ANI provides a safety net type response to support basic needs. We've provided small cash amounts of cash or vouchers or in-kind assistance to enable or to prevent people from resorting to negative coping strategies. Scale up is sometimes required if the emergency extends, and we have been able to provide this early response because within the program there is a pooled fund or a crisis modifier to facilitate these responses. The beneficiaries are households who are most vulnerable to food and nutrition crisis. They are pre-identified through a participatory risk analysis combined with structural vulnerabilities that make the situation more precarious. It is through this pre-identification that we are able to really respond early. Otherwise, it would not make much of a difference if that pre-identification is not done beforehand. Where there's a national social protection system in place, as is the case for Ethiopia, then we follow the same targeting criteria as of the national social protection systems. Should the forecasted emergency manifest, the targeted group may be enlarged to include additional households falling into the same vulnerability criteria. So scale is possible. In other countries, the identification of the second cohort of these of vulnerable households is also normally pre-identified. So that makes the scale up also easy if that structure is there. Otherwise, it would follow the same process as you would in any other emergency in terms of identifying beneficiaries. Next slide, please. To date, we've had 6 responses carried out. We have 4 ongoing and 2 planned. The budget for the crisis modifier is about 35 million. Is about 4.6 out of the 35 million, and can be used, as I said, for both sudden onset emergencies as well as early action. The activation of the pooled fund for early action is based on an early warning system that's developed at the local level. And the information is sourced from existing early warning systems, but also complemented with other information from the communities and other actors on the ground. The final component is around behavior change. As I said, part of the framework for building resilience for this program is behavior change communication. And an interesting model has been, or an interesting approach is being applied, and this is the father to father, mother to mother support group. And these groups have demonstrated to be effective vehicles for change. And through the program, Concern is working with change agents to promote behavior change, as well as linking the same groups to government systems to promote sustainability. Part of what happens within this group is that information is shared on feeding practices, on basic hygiene practices and other aspects that contribute to malnutrition through the groups. The groups provide, act as support mechanisms for each other. Demonstrations are done through the groups, and there's that follow-up and support system that is available to mothers and fathers in terms of behaviors and beliefs that are related to health and nutrition. The focus for these groups is not only on nutritional messaging, but also looks at uptake of health services, or rather health-seeking behavior, hygiene and sanitation practices, but also gender practices or norms that often contribute to the drivers of poor health and malnutrition. These systems are being developed and worked on at community level, whether it is the mother-to-mother support group, or it is the system strengthening that is being done. These are all being done at the local level, which is the most practical approach in the context of fragile and conflict-affected countries. It provides a framework through which nascent governments, as in the case of, let's say, South Sudan, can build on. It provides a platform that nascent governments can build on at community level. But the most important thing, next slide, please. But the most interesting thing about this program is the fact that, one, it is an ambitious program, but the fact that it is a program that is working on a long-term approach in context that would normally be considered as humanitarian emergency context. The planning, pacing, and scaling of what we can achieve with this program could not be done under a one-year program. ANI is about building resilience, and meaningful resilience cannot be built within a short time frame. I mean, Kate, during her opening remarks, talked of quality funding as one of the key enabling priorities of the grand bargain. And I think the PPP program has demonstrated what that quality funding can be. As our experience so far within the ANI is showing us, there are many benefits to having multi-annual flexible funding, as it allows us to work on a multi-annual programming and planning process. Aside from better planning, flexible funding, it also supports nexus programming within the conflict and fragile and conflict-affected countries. The inbuilt flexibility in ANI budgets in each country enables adaptation and allows concern to respond to emergencies as they arise. The timeframe allows for meaningful engagement and capacity development of local actors, such as Ministry of Health in these countries, partners at the local level, but also communities over time. It allows for innovative approaches that integrate prevention and response, as well as adaptation from learning. Under the PPP, there's flexibility, as I said, built into individual country budgets, which is positive. It is a 3-year MOU signed between Concern and ECHO. However, to take this partnership one step further and have one flexible budget to cover the entire program could have been very powerful, rather than separate country budgets which are still linked to the global result framework. While ANI is a 3-year program supported by multi-annual funding under the PPP, and has 5 countries working to one global result framework, it is still linked to the HIP system, the annual HIP system, which means that the final 3-year amount and beneficiary figures are subject to annual confirmation through the HIP allocation process. The fact that this multi-annual grant is being managed year on via HIPs, it risks undermining the long-term goals of the PPP. It's therefore important in terms of ECHO fulfilling its commitment to enhanced quality funding that future iterations of this particular funding modality in terms of multi-annuality and flexibility need to be looked into and find a modality that is not dependent on the annual allocation and get even closer to the true spirits of commitments under the grant bargain. I'll end my presentation here. I think I've taken more than the 15 minutes. My apologies for that.
Thanks, Amina, for that great overview of our experience, recognizing all the positives of having this multi-annual PPP pilot partnership program funding, but also some of the kinks that probably still need to be worked out, as you say, for future iterations. I'm now going to hand over to Barbara Decans from ECHO, who will speak more broadly about that PPP funding mechanism. Over to you, Barbara.
Thank you, Kate, and good morning to all. Let me just a second to share my screen. I guess this should make it share. Can you see my presentation?
Almost. Looks like it's coming. Yep. If you just put it in presentation mode, let us know if that works.
Look better. I'm trying to slideshow. Go ahead. All good for
Perfect.
you?
Yep, looks perfect.
Perfect. So good morning, everybody. I must confess that I'm not a nutrition expert. I'm team leader in DG ECHO with a number of sectoral policies within the team. So apologies for not being an expert. My colleague Andrea Weber is the policy officer for nutrition, but unfortunately she's absent for the time being. And even though I'm not an expert, as you know, in ECHO, we have a network of thematic experts that are located worldwide, basically. So we have colleagues in Amman, Nairobi, Bangkok, Panama, and Dakar. So obviously, even though I'm not an expert, I was supported by colleagues to talk to you this morning, and I'm not totally new to nutrition. So maybe in the sake of time, I think the situation is not the most important point to discuss today. And obviously you're all aware of the importance of the number of children that are stunted and are wasted. And maybe the most important point of the slide is the fact that since the pandemic, the coverage of nutrition services has dropped by 30%. So definitely very alarming situation. I think it has been mentioned by you, Kate, and by, was it Amina? Apologies if I'm mistaken, that has just presented the situation in Niger. What is important is the focus on the longer term approach. And what I want to say here also is the fact that in line with our humanitarian aid communication that has been adopted in March this year, and the humanitarian principles of independence, neutrality, impartiality, and humanity, we follow a strictly needs and rights-based approach. So that's also the reason why we sometimes are reluctant to make a financial commitment just because we want to make sure we answer to the most pressing needs on a yearly basis. So as you know, DG ECHO priorities in terms of nutrition is to avoid or reduce excess morbidity and mortality due to malnutrition in humanitarian situations, and to address immediate as well as underlying causes of malnutrition. So we focus on the treatment of the most vulnerable populations and individual in terms of risk of death, with a specific focus on children under 5 years of age and their mothers suffering from severe and moderate acute malnutrition, in line with the 2013 commitments. In 2019, we did a scoping review of DG ECO nutrition policies. It was an internal document that has helped us to reflect on the evolutions and opportunities in the prevention and treatment of malnutrition in all its forms, and to inform a future nutrition policy. Considering the importance of the basically of the food insecurity situation that has been rising over the last 2 years, we have mobilized a very important and significant amount of additional budget from the emergency aid reserves, 250 million in 2021. And an important share of this food assistance financial contribution is significantly contributed to undernutrition prevention. Just wanted to recall also, but these are figures that you all know, that the Commission Nutrition Commitment, financial contribution to the commitments that were done in 2013 amounted to 4.3 billion, and I'm sure Elena will come back to that, out of which 1.5 billion were coming from the humanitarian assistance budget. So urgent action is needed, and I think you've expressed that already, and not just more of the same. The complex and multi-sectoral nature of malnutrition calls for an integrated multi-sectoral approaches and more predictability of resources forecasting. I will go directly to the next slide, because I wanted to basically respond to your question in with three answers. So the first one is the importance of the nexus approach. As undernutrition is very much a consequence of structural issues that can be aggravated or exacerbated in the case of humanitarian crisis, the triple nexus approach is of particular importance to tackle the underlying and basic causes in the long term. So better than ever, cooperation with other Commission DGs, whether it's INPA or NIR, in the preparation of the MIPS and the annual action plans is of paramount importance, and that is being done at country level for the annual action plans. The same engagement, because this is not only about INPA and ECO and NIR working together, it's also done with member states through the joint programming processes at country level. Beyond DG INPA and DG ECO joint work on nutrition, we encourage implementing partners to engage in advocacy and mobilization of actions to seek new funding sources, including domestic funding, development donors, private sector, and foundations. There's a strong commitment from our side at political level that is carried through to the technical field level. On the country example, I think there's really no need for me to mention Niger to you, nor Mauritania, but for Sudan, nutrition security programming in Sudan stretched from the clinical treatment of severe acute malnutrition to diet diversification by addressing food quality and awareness raising. And this is very much reflected in the programming documents that we have at country level, and the very strong collaboration between the EU delegation in Khartoum and our ECO field office in the country. The second part of the answer is the question of the funding previsibility and the PPPs. We are funding 2 partners on nutrition. We have the partnership with Concern that started 2 years ago almost, 1.5 years ago, and a new PPP with UNICEF. So our expectation, and obviously this is work in progress because well, the program with Concern on the PPP is still ongoing, but our expectation is efficiency gains, transparency, quality in the reporting, about an increased nexus approach, anticipatory action, greater EU visibility, and enhanced dialogue with all partners and governments. The lessons learned from the PPP, basically the importance of the longer term approach, the programmatic planning, enhanced dialogue, increased country cross-fertilization, and coherence. Obviously, there are a number of challenges that lay ahead, and Amina mentioned it, the question of the predictability of the annual budget, the country-based funding, the versatility of the various contexts. I think you mentioned Ethiopia earlier, and obviously the political situation makes it very complicated for the time being, and various requirements and communication channels. As I said, this is work in progress, and fine-tuning is necessary to basically identify the strengths and weaknesses of these new ways of working. And the part 3 of my answer would be the importance of preparedness and early action, and I'm certain my colleague from INPA will go back to that also. We need to be better prepared for a quicker response when it is needed. That is key to increase the resilience. That's from a humanitarian perspective, but obviously it is also valid from a development perspective. In October this year, we have jointly organized with FAO and WFP a Brussels dialogue on anticipatory action to showcase how anticipatory action can contribute to a concrete application of a nexus approach to food crises that obviously are very much linked to the prevention of malnutrition. Our key messages during this dialogue were the following: that we have already financed several pilots and gained experience on anticipatory actions, that we want to build on that experience, and that we make a commitment to step up anticipatory action and make an important part of our toolbox. Anticipatory and early action and early warning systems are crucial for preventing a deterioration of nutrition situation and increase in severe acute malnutrition following shocks and human-made disasters. I think that's all from my side for the time being, but of course I stay tuned and ready to answer questions at the end. Over.
Thank you, Barbara. Very clear. And maybe I'll just move straight into Helena, who is going to speak on behalf of INTPA, the other half of the EU. Thanks.
Yeah, thank you, Kate, and thank you, Barbara. Good morning, good afternoon to everybody. Please give me a minute to share my screen. Kate, can you see it now, or?
We can, if you can just put it in slideshow mode, you should be ready to go.
Yeah, now is it okay?
Yep, perfect. Okay,
perfect. Thank you very much. And thank you to Concern for inviting me to this N4G event. So my presentation will focus on investing in universal health coverage as an essential component of the European Union's multi-sector approach to nutrition, and I will share with you a couple of lessons learned from our EU action plan on nutrition. So first, I will refer to our two global commitments, which were already mentioned by Barbara. These commitments were made at international level by our development commissioner. The first one on reducing child stunting, contributing to the WHO target by reducing the number of stunted children by at least 7 million by 2025. And the second commitment made in the process of Nutrition for Growth in the first summit in 2013 in London. And it was about investing in to improve nutrition in partner countries. The pledge was 3.5 billion between 2014 and 2020. So you can see that there is a complementarity of the focus of INTPA. Investments are more on, let's say, longer perspective, reducing child malnutrition, very complementary to the ECO's action on child wasting. The EU action plan built on these two commitments and has three main strategic priorities: to enhance mobilization and political commitment for nutrition, scale up actions at country level, and strengthen knowledge and for nutrition. Our action, let's say the development cooperation investments are concentrated in 42 countries with high burden of starting and where the government prioritized investments in nutrition in the cooperation program with the European Union. We report annually within our progress reports on the advancement, on the implementation of the action plan, and the last this year report is focusing on the analysis of the progress, but also to inform the discussion, the ongoing discussion of the Commission's future role in nutrition, because it is it marks a critical juncture between two programming cycles, 2014-2020 and 2021-2027. I can share this report with you after the seminar. Maybe to mention that the programming exercise for 2021-2027 is still ongoing. According to our preliminary analysis, nutrition could feature to varying extents in 55 multi-annual indicative programs, and mainly under the Green Deal priority, but also under sectors falling under the human development, including health. So what are the main messages from our sixth progress report? So we are happy to announce that our pledge to invest 3.5 billion was met in 2019 already, and that the total common amount of the nutrition investments between 2014 and 2020 amounted to 4.3 billion, of which 1.5 billion from humanitarian assistance, as mentioned by Barbara, and 2.8 billion from INTPA. There was also a positive progress in reducing prevalence of stunting by an average of 6.2 percentage points, and also some progress in many countries in other nutrition targets, in particular wasting, low birth weights, and exclusive breastfeeding. And regarding challenges, so this relates mainly to conflicts, climate change, and the ongoing pandemic. And these also reinforce the key role of good nutrition and healthy diets for physical and mental development of children and mothers, and for enhancing their immune system function. And so very important in the context of the current pandemic. The next slide relates to, it's actually a screenshot from our sixth progress report. And just to show you that in this report, we also analyzed the lessons learned from our ongoing or concluded operations. The European Union, let's say the projects you can see on the screen relates to different geographical regions, but also to different priorities. I just mentioned it, the red to the political commitment, the blue to the scaling up delivery of nutrition, and orange to the knowledge in nutrition. So of our particular interest is the one in Burkina Faso, which is a sectoral health budget support program implemented from 2016 to 2020. And it's an example of Commission's commitment to strengthen national health system with a focus on the integration of nutrition-related actions. I will explain the outcomes of this program a bit later, but I would first just like to share with you the general outcome of the analysis of these programs. And is it that what works best for improved nutrition is a locally adopted, sustained, multi-sectoral and right-based approach with a strong focus on tackling structured inequalities related to gender and related to wealth. And this is also the case in conflict-affected countries. And this multi-sectoral approach will also continue to be the main focus of the EU efforts in the next programming. So on the next slide, I would like to share with you some main features of the EU approach in supporting universal health coverage. So the EU is active in different global initiatives, and the key component is also this multi-sectoral approach. Strong emphasis is based on national ownership in terms of supporting our partner countries in identifying qualitative and necessary health services, enhancing access to these services, and taking the necessary measures to ensure that seeking quality healthcare does not result in further impoverishment. So meaning to proceed in the most sustainable way possible. It is also crucial that national institutions hold the leading role in designing and implementing reforms aimed at strengthening their health systems, and that the European Union is there to support them. So in this respect, health financing policies defined by our partner countries play a crucial role in laying down the path towards achieving the universal health coverage. In fact, these policies determine how available domestic and international resources are used to finance a given set of health services, and how payment for these services is shared between state and the population. So this is very important, the ownership of the national government. And yeah, we have this holistic approach to health system strengthening, and this involves all 6 building blocks as defined by WHO: health service delivery, workforce information systems, essential medicines, financing, leadership, and governance. On the next slide, I would like to share with you the main data on our sectoral health budget support program in Burkina Faso. The main objective is building on several years of the EU humanitarian assistance, including treatment of severe acute malnutrition. And so this budget support supported national efforts to strengthen public systems for the achievement of the universal health coverage, including nutrition services. The main achievement can be mentioned at the creation of a national budget line for the purchase of therapeutical food. So the number of children affected by severe stunting and supported by the government's therapeutical food budget line increased from 0 in 2016 to 110,000 in 2019. Also, one of the achievements of the program is indication of indicators for tracking both the quality of acute malnutrition management and the number of children in care within the health system, and ensuring annual nutrition data to reinforce government commitment and accountability at all levels. So this modality of the budget support also responds to the call for multi-annual funding and commitment from a national system to provide this, this perspective. It contributed to building the social contract between families and the health system, together with a political commitment required to ensure that the most vulnerable are not left behind. And to complement the answers from Barbara on the joint action or coordination between the INTPA and ECHO, I would like to mention the triple nexus between humanitarian aid, peace building, and development. So in recent years, this triple nexus has become a critical component of our partnerships, and will become even more relevant in the next programming. It is based on the principle that just a lasting peace cannot be built on foundation of hunger and malnutrition. Likewise, the eradication of hunger and malnutrition will never be achieved in the context of an armed conflict. So the main approach is to have context-specific engagement, do no harm principle, flexibility, and a conflict-sensitive approach when tackling hunger and malnutrition, and building resilient universal health coverage systems in fragile context. We have to say also that the implementing of this triple nexus approach is still in its early stages and is not without challenges. But we still need to enhance the flexibility and ability to fund rapid response, as well as development activities to enhance coordination, coherence, and complementarity between various initiatives. This is a key step. And actually the most important is that the actors in development, humanitarian, and peace building operations are coordinated and focused on what is the best for the populations, and that local actors are also involved, provided with capacity building, and supported with resilience building activities. So I would like to thank you for your attention, and of course I'm also available to reply to some additional questions if needed.
Thank you, Helena. We'll move on to our last two presentations, and then fantastic, you'll be available to answer questions for our last probably 20 minutes. We're just a little bit behind time, but we're doing okay. So I'm going to hand over to Mado Diakite, who is speaking on behalf of the government of Niger. She's a technical assistant to the government there on food and nutrition security. And I'd like to remind anyone who would like to hear what Mado is saying in English, because she'll be speaking in French, but her slides are in English, to turn on the translation. And Mado, if you can just let Gillian know when you need her to move to the next slide, that would help, because she can't see exactly when you need to move. Okay, over to you, Mado. Thank you.
Thank you very much. Hello everybody, bonjour à tous. Je vais donc parler en français pour vous présenter donc la contribution du Niger à ce side event, et en particulier partager certaines avancées, certaines leçons apprises et certains défis qui subsistent au Niger. Et vous verrez qu'on rebondira sur certains sujets qui ont été abordés par les panélistes précédents. Donc pour aller à la diapo suivante. Merci. Donc, on abordera globalement finalement, comment est-ce qu'on a progressivement intégré la nutrition dans le système sanitaire au Niger depuis les grandes crises, enfin principalement la crise de 2005 et les opportunités et les défis que représente cette intégration. On partagera également des réflexions et des expériences sur comment on gère la continuité des services en nutrition dans un contexte de fragilité et comment finalement renforcer la prise en compte d'une approche Nexus. Donc, on évoquera à la fois le fait que il faut garder une capacité à répondre à des pics de malnutrition aiguë sévère, des pics saisonniers que Amina a évoqué déjà plus tôt, mais aussi comment on prend en compte le fait que dans certaines zones qu'on appelle ici au Sahel les zones fragiles ou les zones d'instabilité, comment on fait face finalement à la baisse des services du delivery des services sociaux de base et aux baisses des capacités de l'État à assurer la continuité des services. On évoquera rapidement la politique multisectorielle de sécurité nutritionnelle, dont vous avez peut-être entendu parler, qui est un processus qui a été appuyé au niveau international par de nombreuses agences qui participent au sommet N4G. Et puis, on parlera de la question des financements et en particulier de comment on mène la transition entre des financements qui étaient avant tout humanitaires par le passé à des financements qui se veulent beaucoup plus structurants, beaucoup plus durables, mais qui devraient demeurer flexibles. Donc, la diapo suivante. Voilà, donc très rapidement, la nutrition, les enjeux de la nutrition dans le système sanitaire au Niger. Donc, on a de manière structurelle un très fort, un nombre d'enfants à traiter, des besoins très importants. Hein, là, on a des chiffres depuis 2010, mais et on a même les chiffres de 2020 qu'on n'a pas mis, qui sont les plus hauts jamais atteints. On est à 420 enfants à peu près qui ont été pris en charge en 2020. Et on voit que c'est bien une situation qui est structurelle, qui est durable, qui est dans le temps et qui nécessite donc d'intégrer pleinement la réponse à ce défi au système sanitaire et non pas une logique d'urgence et de réponse à des pics. Même s'il est vrai qu'on a des pics saisonniers récurrents qui sont bien connus au Sahel sur la période dite de soudure entre juillet et septembre. Il faut noter aussi qu'on a le défi crucial au Niger de devoir faire face à une croissance démographique qui est la plus importante du monde, même si elle est en train de légèrement baisser depuis 2020. Et d'ailleurs, on constate que finalement, malgré le fait que sur la période des données qui est indiquée dans le graphique, on a doublé la population, on en reste à un niveau d'enfants pris en charge qui est à peu près stable, ce qui peut poser la question de la couverture. Donc, depuis 2005, on a vraiment fait des énormes progrès dans beaucoup de composantes pour intégrer la nutrition au système sanitaire. Désormais, évidemment, les services nutritionnels font partie intégrante du paquet minimum d'activité des centres de santé et partie intégrante du plan de développement sanitaire quinquennal qui est renouvelé régulièrement par le ministère de la Santé. Mais on n'a pas seulement intégré pleinement les centres de prise en charge et le défi de la prise en charge médicale, mais on a aussi intégré de plus en plus dans les politiques sanitaires les activités de prévention et les activités même promotionnelles dans le domaine de la santé. Par exemple, évidemment, tout ce qui est activité nutritionnelle dans le contexte des 1000 jours, dans la fenêtre des 1000 jours, donc les consultations prénatales, les supplémentations en fer et vitamine A, les pratiques ANGE, les bonnes pratiques d'alimentation du nourrisson et du jeune enfant, etc. Ce processus d'intégration a été aussi permis du fait que la stratégie de sortie, il y a eu une réflexion sur une stratégie de sortie progressive par les acteurs humanitaires. On sait que le Niger, c'est un petit peu le cas d'espèce pour ECHO qui a financé très longtemps à des niveaux très importants la prise en charge de la malnutrition et qui, depuis 2012, que ce soit via l'initiative Agir ou désormais via une collaboration, une coordination stratégique avec DEFCO, essaye de trouver des moyens de transférer une partie des coûts de la prise en charge de la malnutrition depuis les financements, les outils humanitaires vers des outils de développement. Et ça a entraîné des pratiques intéressantes d'exit stratégie progressive, y compris de la part des ONG partenaires de ECHO qui ont élaboré des plans de transition pour permettre aux centres de santé sur le terrain et aux districts sanitaires de progressivement finalement mesurer les implications du retrait et prendre le relais sur un certain nombre de compétences et de coûts. Globalement, bon, on le sait maintenant, hein, la prise en charge de la malnutrition aiguë sévère et les énormes efforts qui ont été menés depuis 2005 et qui ont été progressivement généralisés et maintenus à travers le territoire ont contribué directement à réduire la mortalité des enfants de moins de 5 ans au Niger et donc d'atteindre certains OMD et désormais d'être sur la route des ODD. Après, pour ce qui est d'intégration pleine et entière de la nutrition et en particulier de la prise en charge de la malnutrition aiguë sévère dans les systèmes sanitaires de manière structurante, il y a encore d'énormes défis à relever. Hein. On est sur la voie, il y a des avancées très intéressantes qu'il faut signaler, mais évidemment, quand on regarde plus en détail certaines questions opérationnelles et techniques, on a encore des freins très importants. On a évidemment la question de l'approvisionnement en aliments thérapeutiques prêts à l'emploi, donc les achats, les stratégies d'approvisionnement et de transport à travers tout le pays, dans tous les centres de santé, ça reste un défi très important parce que finalement, c'est un produit qui n'est pas totalement intégré à la liste des produits pharmaceutiques qui sont gérés par l'Office national des produits pharmaceutiques. Donc là-dessus, il y a encore un travail d'intégration qui reste à faire, même s'il est en train de progresser, on y reviendra. Et on remarque, par exemple, c'est que pour citer quelques exemples de défis, hein, mais on remarque que les formations en nutrition sont encore assez faibles dans les curricula des écoles de santé. C'est souvent plutôt des formations, des formations qui sont amenées ensuite sur le tas pendant que les agents de santé sont déjà en service, mais ce n'est pas totalement intégré encore ces compétences-là aux formations de base des agents de santé. Et puis, on remarque que, malgré ce que je disais plus tôt, lorsque les ONG finissent leur soutien aux centres de santé dans certaines zones, on voit une diminution finalement du nombre d'admissions, comme si finalement il y avait un moindre recours au service quand on savait que l'assistance externe n'est plus assurée. Donc voilà, des progrès, mais encore de nombreux signes que cette intégration n'est pas tout à fait complétée et qu'il y a encore du chemin à faire. La diapo suivante. Donc, justement, on se rend compte que si il y a encore du chemin à faire, c'est que malheureusement, on considère encore trop souvent la nutrition comme un service sanitaire un peu à part. Il y a encore énormément de pratiques, que ce soit de manière opérationnelle, en termes de financement, en termes de partenariat, qui font qu'il y a le risque de continuer à être sur un système un petit peu parallèle. Comme évidemment, on tient à maintenir des services de prise en charge de la malnutrition aiguë sévère, on tient à sauver des vies, on tient à assurer la performance des services pour lesquels un grand nombre de partenaires sont financés, on peut avoir tendance finalement à mettre en place des systèmes un peu parallèles, du moins sur certains segments du système de santé. Donc l'idée, ça serait vraiment de continuer les efforts, de voir comment vraiment améliorer, renforcer le système sanitaire à travers le soutien à la délivrance de services nutritionnels. C'est-à-dire que c'est pas simplement, on sait que la nutrition doit être intégrée au système de santé, on sait que les systèmes de santé sont encore structurellement très fragiles, en tout cas que dans un pays comme le Niger, qui est non seulement un des plus pauvres du monde, avec la croissance démographique la plus forte, avec les effets du changement climatique, avec désormais les effets de l'insécurité dans la sous-région du Sahel. Donc, on sait pertinemment que le système de santé lui-même est encore très fragile et du coup, il faut voir comment finalement l'intérêt et le travail sur les services nutritionnels peuvent contribuer, peuvent être promoteurs, peuvent susciter, peuvent catalyser le renforcement des systèmes de santé. Là, on rappelle le framework de l'OMS dont Elena, il me semble, a déjà parlé. Donc, l'idée, c'est vraiment de continuer à encourager tous les acteurs à aller de plus en plus vers une approche systémique en s'inscrivant et en soutenant les outils et les processus qui sont globaux du secteur de la santé. Plutôt que d'être tenté peut-être par mettre en place des systèmes ou des initiatives un petit peu parallèles, peut-être plus efficaces à court terme, mais dont les effets à long terme ne sont pas forcément garantis sur le renforcement du système de santé. Donc, comme je disais plus tôt, l'intégration des aliments thérapeutiques prêts à l'emploi, ça reste un vrai enjeu pour qu'ils soient finalement traités, considérés par le ministère de la Santé au même titre que n'importe quel médicament n'importe quel intrant qui doivent arriver dans les centres de santé. D'ailleurs, on remarque qu'il y a encore des efforts qu'on peut faire, des marges de progrès qu'on peut faire. Alors, bien qu'on ait au Niger, évidemment, une usine de production d'aliments thérapeutiques prêts à l'emploi, le gouvernement du Niger pourra encore faire davantage d'efforts pour lever un certain nombre de taxes sur les produits qui sont importés de manière à fabriquer ces intrants-là. Donc là, il y aurait aussi un sujet intéressant un peu d'économie faite sur les aliments thérapeutiques prêts à l'emploi. Quand l'État prend conscience que c'est à lui de les acheter, il va sans doute voir comment aussi tout faire pour les rendre plus accessibles. Ça a été évoqué par Elena, comment faire en sorte que finalement la nutrition soit pleinement intégrée, mais contribue aussi de manière à une gratuité des soins qui soit plus effective. On sait que la gratuité des soins connaît des problèmes très importants au Niger, qu'il y a à peine 40% des factures qui sont remboursées par l'État, qu'il y a des milliards d'arriérés. Et comment aussi intégrer la nutrition et la problématique du financement de la nutrition dans le chantier actuel de la couverture universelle en santé ou de la couverture santé universelle qui est en cours, qui est une question qui est d'actualité dans beaucoup de pays du monde. Et encore une fois, pour intégrer la nutrition dans une perspective globale du système de santé, il y a aussi la question de ne pas prendre en compte uniquement les pics de malnutrition, les pics saisonniers de malnutrition, mais évidemment de réaliser qu'ils s'intègrent dans d'autres pics sur d'autres maladies, le palu, les maladies respiratoires, etc. Et que du coup, cette gestion des pics-là doit être intégrée. On y reviendra quand on parlera de Simam Surge et de son évolution récente au Niger. Donc, voilà, c'est des défis qui sont importants. Évidemment, on cherche à améliorer la couverture des services de nutrition. Il y a énormément d'initiatives, que ce soit le PBMR, le protocole simplifié, etc., dont la porte d'entrée, l'angle, c'est de comment améliorer la couverture, comment être sûr qu'on soit efficace à ne laisser passer aucun cas. Mais d'un autre côté, ça veut dire une augmentation des besoins des personnes qui arrivent dans les centres de santé. Et donc, ça pose aussi le challenge de cette intégration aux structures sanitaires et à leurs capacités actuelles. À la diapo suivante. Donc, ajouter à tous ces challenges un peu structurels d'intégration de la nutrition dans le système sanitaire, il y a évidemment les spécificités propres au contexte de fragilité que le Niger connaît, mais comme les pays dont Amina parlait plus tôt aussi connaissent, et comment finalement avancer, aller vers une approche Nexus, une approche un petit peu plus intégrée entre les besoins à court, moyen et long terme. Donc, le contexte fragile, ça implique non seulement qu'il y ait des pics en termes de besoins, Et attention, ces pics ne sont pas forcément saisonniers. On a parlé des pics en période de soudure, mais là, le schéma, par exemple, qui est mentionné ici en bleu, on a un pic ici qui est lié à un afflux d'enfants nigérians qui traversent la frontière et qui, dans certains centres de santé frontaliers, viennent chercher le service au Niger plutôt qu'au Nigeria, où les zones du nord-ouest du Niger, mais aussi du nord-est du Nigeria, pardon, sont très affectées par l'insécurité, ce qui pose un énorme problème de continuité des soins et d'accès même des acteurs humanitaires à ces zones-là. Donc, on peut avoir des pics ou des situations exceptionnelles qui ne soient pas seulement liées à des facteurs saisonniers, mais à des facteurs tout à fait autres, tel que là, le cas d'une arrivée massive d'enfants nigérians. Et l'autre aspect de la fragilité que je mentionnais plus tôt, c'est que parfois, on ne va peut-être pas avoir une augmentation aussi évidente des besoins, mais par contre, on va avoir une réduction de l'offre de la continuité des soins importante à cause de l'insécurité, à cause du fait que le gouvernement n'arrive plus à maintenir des centres de santé dans certaines zones particulièrement instables, mais aussi du fait que certains acteurs humanitaires ont des difficultés d'accès si le dialogue avec le gouvernement et les groupes sur ces questions-là n'est pas fluide. Ça rend du coup évidemment crucial l'enjeu d'une approche Nexus. Ici, j'ai simplement reproduit un extrait du policy brief qui a été produit suite à des case studies au Niger et dans d'autres pays. Il me semble que c'était Yémen et Somalie, mais j'ai peur de me tromper. Et donc, voilà, ça rappelle qu'en effet, l'enjeu du Nexus, c'est vraiment des mécanismes de coordination, de dialogue, une vision intégrée, la recherche d'actions structurantes, etc. Dans ce domaine-là, on a quand même, il faut le noter, et ça a été mentionné un petit peu, le côté laboratoire ou innovant ou précurseur du Niger. On a énormément d'expériences intéressantes pour intégrer la gestion des pics, mais aussi la gestion des fragilités dans le domaine de la nutrition. Il faut d'abord mentionner que le plan national de réponse, donc les plans de soutien aux populations vulnérables qui sont élaborés chaque année par le gouvernement du Niger pour la période de soudure, intègrent systématiquement des activités nutritionnelles, donc soit une augmentation de capacité de prise en charge, mais aussi de la prévention avec la distribution par le gouvernement de farines enrichies, bien souvent des farines locales, puisque c'est la fortification et l'enrichissement des farines locales, c'est quelque chose qui est très soutenu, y compris par l'Union européenne. On a évidemment des expériences issues des nombreuses ONG, en particulier partenaires d'ECHO, qui travaillent depuis de longues années sur le soutien aux structures sanitaires pour prendre en charge la malnutrition. Et on a évidemment toute l'expérience CIMAM Surge de Concern, de manière à pouvoir anticiper et prévoir un peu sous forme de contingence une augmentation de la capacité de prise en charge pour s'adapter au contexte, mais aussi tout un plaidoyer. Concern a également intégré tout un plaidoyer et toute une démarche de dialogue avec le ministère de la Santé pour intégrer ces pratiques et cette expérience CIMAM Surge dans les politiques et stratégies nationales. Et ce qui est d'autant plus intéressant quand on pense à l'interface entre nutrition et système de santé, c'est de voir comment on évolue finalement vers un health search plutôt qu'un CIMAM search, en se disant on ne peut pas aider juste une structure sanitaire à s'adapter aux pics de nutrition, au risque de déstabiliser la continuité des soins sur d'autres pathologies qui parfois ont des pics en même temps, comme je mentionnais tout à l'heure, le palu, les infections respiratoires, le choléra, etc. Donc, comment finalement on élargit un petit peu cette approche d'appui au scale-up des services de manière un petit peu plus intégrée. Donc, malgré toutes les avancées et le très bon dialogue qu'il y a entre les acteurs et le ministère de la Santé sur ces questions, on est quand même confronté à des problèmes fondamentaux qui sont comment on systématise la prise en charge de coûts du personnel additionnel lorsqu'il est nécessaire. C'est parfois fait par les communes, mais ça dépend beaucoup de la volonté des collectivités et de la proactivité des chefs de district de répondre d'assurer ces coûts-là et de s'intéresser finalement à cette question de la mise à l'échelle des services. Et puis, on a évidemment la question de l'approvisionnement à travers tout le territoire des aliments thérapeutiques prêts à l'emploi, qui reste évidemment un défi logistique énorme et non pas seulement financier. On a aussi des exemples intéressants, plus récents et toujours un petit peu sous l'impulsion des partenaires de ECO pour maintenir des services de santé dans les zones fragiles à travers évidemment le Rapid Response Mechanism qui permet de soutenir les capacités des services de santé dans les zones qui accueillent des personnes déplacées ou des réfugiés par exemple, mais aussi de déployer des cliniques mobiles dans les zones fragiles là où ça semble plus adapté et là où des services, les centres de santé ont fermé pour des raisons d'insécurité. Bien souvent, les agents de santé sont menacés ou ont peur de rester dans des zones frontalières du Mali, du Burkina ou du Nigeria. Et donc, on est confronté à cette situation. Les services de santé essayent de rester ouverts aussi longtemps que... de ne pas fermer, mais parfois, il faut réduire les horaires d'ouverture pour éviter que les gens se déplacent la nuit, etc. D'ailleurs, on peut noter ici que dans le cadre du sommet Forgy, le Niger va prendre un engagement pour le maintien, d'essayer d'assurer la continuité des soins dans les zones fragiles, ce qui est vraiment un défi important.
Mado, sorry, I hate to rush you because this is really,
okay, I'll finish
very
up
rich
quickly.
stuff. Would you mind? Sorry, just I want to make sure we have a little bit of time for Q&A. Thank you.
Yeah. I'll try to finish within 3 minutes. Donc, l'enjeu important pour ces questions de réponse au pic et de prise de décision pour s'adapter à une hausse de la demande, c'est l'enjeu des données qui permettent de déclencher des alertes ou qui permettent de prendre des décisions. Et là, c'est un sujet qui est tout à fait d'actualité sur est-ce qu'on reconnaît les données issues de la déclaration des maladies à déclaration obligatoire ou bien d'un système d'information au niveau central. Et ça, c'est vraiment les enjeux du moment sur lesquels il faut travailler. On peut aller à la diapo suivante. Voilà, donc un autre défi, évidemment, ce serait d'adresser la prévention et de financer des programmes de prévention de la malnutrition et de réduction de la malnutrition chronique en particulier à travers une approche multisectorielle. Et ça, c'est un sujet sur lequel le Niger, évidemment, est en première ligne. Vous avez peut-être entendu parler de la politique nationale de sécurité nutritionnelle qui permet des actions multisectorielles, convergentes et coordonnées. Et qui a permis de mettre en place des mécanismes de gouvernance et de coordination à haut niveau, en particulier sous le pilotage du Haut Commissariat administratif 3N qui dépend de la présidence. Mais après 5 ans de mise en œuvre de la PNSN, on a aussi constaté des vraies difficultés à intégrer vraiment l'intégration dans les stratégies sectorielles, à avoir des indicateurs sensibles à la nutrition qui permettent un suivi et une redevabilité sur les effets qu'on a concrètement sur la prévalence. On a du mal à assurer la traçabilité et la visibilité des budgets associés à cette politique. Mais il y a un nouveau plan d'action qui est en cours d'élaboration qui doit tirer les leçons de la phase précédente. Et on a la plateforme nationale d'information sur la nutrition financée par l'Union européenne et ancrée à l'Institut national de la statistique du Niger qui aide énormément à la prise de conscience de l'importance d'avoir tous les secteurs contributifs, éducation, agriculture, protection sociale, etc., qui jouent pleinement leur rôle pour prévenir la malnutrition. Donc, à la diapo suivante, on en arrive aux enjeux du financement. Donc, on sait qu'il y a une réduction progressive, mais drastique, flagrante, des financements humanitaires, alors qu'on a des besoins qui sont stables, comme on le voyait sur la première diapo. On a le coût très important pour assurer les aliments thérapeutiques prêts à l'emploi sur toute l'année. Ça représente aujourd'hui à peu près 12 millions de dollars par an, rien que les achats d'aliments thérapeutiques prêts à l'emploi. On sait que le premier plan d'action de la PNSN a été largement sous-financé et que il y a à peine 1,5% du PIB ou 3% du budget national qui est consacré à la nutrition. Mais malgré tout, il y a des vraies avancées en termes de transition vers des financements plus durables. On a la fameuse feuille de route pour la transition des coûts de la prise en charge de la malnutrition par le ministère de la Santé, qui a été adoptée par le ministère de la Santé un peu sous l'impulsion d'un appui budgétaire de l'Union européenne, même si on est loin malheureusement du modèle du Burkina où on aimerait que les appuis budgétaires soient utilisés de manière beaucoup plus proactive pour la nutrition dans le système de santé au Niger. Mais ça a quand même permis des avancées importantes et en 2021, là, on vient d'enregistrer l'achat de 1,5 million de dollars d'intrants nutritionnels par le gouvernement qui va permettre de couvrir les besoins de 300 000 enfants. On est à moins de 10% des besoins, mais c'est un début, c'est vraiment quelque chose qui est à saluer parce que ça a été, c'est le résultat d'un processus où les acteurs humanitaires, ECHO, les partenaires, DEFCO, l'ensemble des bailleurs de développement ont vraiment poussé pour cette évolution structurante au niveau du budget du ministère de la Santé. Mais idéalement, il faut vraiment intégrer la problématique du financement de la nutrition au mécanisme de financement de la santé en général. C'est vraiment comme ça qu'on arrivera à ce qu'on cherche comme effet, que ce soit en passant des financements à travers le Fonds commun santé qui existe au Niger ou à travers de l'appui budgétaire, comme on le mentionnait plus tôt. Donc, on doit encore mobiliser davantage les acteurs de développement, les bailleurs de développement, puisque c'est leurs outils qui peuvent vraiment avoir un effet structurant et durable. Et on a de la chance d'avoir un très bon niveau de dialogue au Niger entre l'État et les acteurs non étatiques, mais aussi entre les acteurs humanitaires et de développement. Et donc ça, c'est quelque chose c'est une dynamique qui se poursuit. Et d'ailleurs, l'Union européenne a commandité récemment une cartographie des bailleurs en nutrition qu'on espère pouvoir diffuser prochainement et qui pourrait devenir un outil de plaidoyer auprès des bailleurs de développement pour poursuivre les efforts et avoir vraiment un effet plus visible et plus concret sur la transition des financements vers les instruments de développement. Et la dernière diapo, très rapidement, donc les conclusions. L'idéal, c'est vraiment de considérer qu'en travaillant sur l'amélioration des services nutritionnels, on contribue à renforcer le système de santé. Et quand on contribue à renforcer le système de santé, ça aura évidemment un impact sur l'amélioration des services nutritionnels. Donc, il faut continuer à promouvoir une approche systémique dans l'augmentation des financements, et aussi dans l'efficacité de la dépense. Il faut continuer à construire le dialogue multisectoriel et la gouvernance globale qui est à un niveau élevé au Niger grâce à l'ancrage du Haut-Commissariat à l'initiative 3N à la présidence, au cabinet du président de la République. Et il faut vraiment bâtir sur l'opportunité que représente la qualité du dialogue au Niger. L'enjeu, c'est vraiment de mobiliser davantage de fonds structurels de développement pour continuer à renforcer le système de santé et ainsi la durabilité des services nutritionnels. Mais il faut évidemment ne pas perdre de vue la nécessité de rester flexible. Et ça, il y a énormément de réflexions sur comment avoir des fonds communs qui permettraient d'assurer cette flexibilité pour répondre à des pics et à l'effet des chocs qui sont de plus en plus divers au Niger et qui représentent un vrai défi. Il faut maintenir une capacité de délivrer les services et surtout assurer la redevabilité, puisqu'on sait que la feuille de route du ministère de la Santé avait suscité beaucoup d'espoir, mais que finalement, ça a été assez difficile d'assurer que le gouvernement respecte ses engagements et atteigne les objectifs qui avaient été définis. Désolée, j'ai été un petit peu long, mais ça permet d'illustrer un peu le foisonnement d'initiatives sur cette problématique-là qui existe au Niger. Merci beaucoup.
Thank you so much, Madhu. And you've actually preempted many of the questions that I might have asked in our Q&A. So I'm not going to waste another minute. I'm going to hand over to Patrick, our last speaker. And Patrick, if you can just let Gillian know if and when you'd like her to start your slides, that'd be great.
Okay, happy to do that. Thanks, Chair, and many thanks to the concern for the invitation to attend today's event. Friends, I think we can all agree that good nutrition is the most significant maker and marker of human development. And as such, good nutrition therefore mutually reinforces the 4 policy priorities in Ireland's international development policy. And I suppose my remarks today, to put a caveat across, I'm not a nutrition specialist. I'm the Deputy Director of the Policy Unit in Irish Aid. So my remarks would be sort of from a policy perspective, an Irish Aid policy perspective. So within our international development policy, A Better World, we have 4 key policy areas: reducing humanitarian need, gender equality, strengthening governance, and climate action. And we believe nutrition and good nutrition is actually relevant to all of those. All of them, in fact, being framed by the overarching objective to reach those furthest behind first. This requires a consistent focus on those whose fundamental human rights, including the right to adequate food, are threatened or denied by intersecting forms of deprivation and marginalization, being malnourished children, women unable to access health care, people living with disabilities, or smallholder farmers whose livelihoods are threatened by climate change. Vulnerable, marginalized, and poor populations are the most affected by undernutrition. In order to reach them, as with all the presentations made by my colleagues earlier, we know that interventions for the prevention, detection, and treatment of undernutrition are needed at scale, alongside a coordinated and expanded nutrition-sensitive approach, which is both multi-sectoral and multi-stakeholder. Ireland, for its part, has historically supported a wide range of nutrition interventions and programs, with a particular focus on preventing undernutrition in early childhood, especially by targeting the 1,000-day window of opportunity from pregnancy to the age of 2. Improving infant and young child feeding practices and promotion of exclusive breastfeeding for infants up to 6 months of age are a particular priority for us. In humanitarian and crisis situations, we support emergency responses to food crises, including programs that support the treatment of acute malnutrition in people's homes or in community clinics instead of crowded hospitals. Community management of acute malnutrition, or CMAM, and we heard a really interesting presentation on CMAM's surge from our Concern colleague earlier. But CMAM itself was first piloted and developed by Concern Worldwide with Irish Aid funding actually some 20 years ago before being rolled out worldwide. CMAM has indeed been a signature success story in both prevention and treatment of wasting, with evidence pointing to its capacity for significant scaling and further impact. Reducing humanitarian need means anticipating and, where possible, preventing as well as responding to crises, so as to protect the most vulnerable and those at risk. This focus on prevention as well as treatment of child undernutrition is important. Prevention is often overlooked in emergencies to the detriment of longer-term improvements in nutrition across generations. Ireland's commitment to reach those furthest behind first indeed provides an opportunity to focus on maternal nutrition, which is frequently under-resourced in humanitarian settings, but is integral to protecting infant and child nutrition, as well as that of the mother herself. Ireland's commitment to education, health, and social protection in emergency settings as basic elements of a functioning system also provide opportunities to advance nutrition outcomes. Nutrition gains can be maximized by ensuring that efforts towards each of these elements, as well as to the whole system, are adapted to be nutrition sensitive. We know that there are promising examples of nutrition sensitive multi-sector responses in protracted crises that are becoming more evident in practice and in the research literature. All 17 of the Sustainable Development Goals rely, at least to some degree, on healthier, more sustainable and equitable food systems, making them absolutely central to the achievement of the 2030 Agenda. In conjunction with food systems, global health and social protection systems are critical vehicles for combating malnutrition. However, these systems, generally operate in silos, and all have been weakened by the impact of COVID-19. So coordinated work across these systems is essential in order to prioritize and scale up high-impact nutrition interventions. Building on the recent UN Food Systems Summit, and now through the Nutrition for Growth Summit, Ireland will make two main policy commitments. First, we will support innovative programming approaches for the prevention and treatment of wasting, with a particular focus on tackling wasting in children under 6 months of age. Second, we want to share our own experience of developing our National Food Vision 2030 strategy as part of the Food Systems Transformation Pathways as a follow-up to the Food Systems Summit. Our emphasis will be to support partner countries as they develop their own strategies, emphasizing nutrition and context-specific approaches. Maybe Gillian can begin to put up the slide. At the Food Systems Summit, Ireland participated very actively in the wasting reset process with all our member states, NGOs, and various stakeholders. 6 key areas, as was mentioned earlier, were identified, and one of these was around the area of financing to address undernutrition. A subgroup worked up 4 key messages, and I'd like just to point to those very briefly. The first one is that we need to increase our political and financial commitments to achieve zero hunger. It is estimated that up to $12.6 billion per year is urgently needed in financial commitments to reach the Sustainable Development Goal 2 targets by 2030. For sure, therefore, political momentum is required to ensure these financial needs are met, from domestic resources in country, international donors, philanthropists, and private sector contributions. Ireland, for its part, will be making a substantial financial commitment at the Nutrition for Growth Summit. Ireland remains one of the highest donors as a percentage of ODA to nutrition, and we aim to and expect to continue to play that leadership role globally. Last year, Ireland committed nearly 19% of its ODA to nutrition. Secondly, more accurate and comprehensive financial estimates are required for wasting prevention. The number above I mentioned includes only the cost of severe wasting treatment. The costs of treating moderate wasting and preventing wasting have not been included. Yet we know that if we focus purely on severe wasting treatment, sustained reduction in the numbers of children becoming wasted each year will elude us. So for improved advocacy and programming, we need more comprehensive financial estimates on wasting prevention that also complement our stunting prevention work, which is part of the broader multi-sector approach to nutrition. For Ireland's part, we will continue to be committed to having better data, better information in which to inform our programming decisions. Thirdly, financing mechanisms and flows need to be more sustainable and effective. As mentioned by some others, alongside the humanitarian funding, longer term and more flexible funding is needed. And I think that has come out strongly in the presentations so far, both for sustainable wasting treatment and also for wasting prevention. This requires funding that builds resilience into health, food, and social protection systems. Funding should prioritize cost-effective, scalable, and proven measures. For bilateral and multilateral donors at the country level, including in some fragile contexts, this also means, after proper risk assessments, supporting and using government systems as much as possible. Funding should preferably be at least on plan, on budget, and on audit. And what we mean by that is that funding mechanisms and funding support should roll in behind the national development plans and national health plans, should be recognised within government budgets, and should indeed be audited through government systems, audit systems. For Ireland, pooled donor funding arrangements in support of government health and other systems are our preferred modality. Importantly, we believe this can improve the quality of sector dialogue with government in important areas, as we've been discussing today, with national nutrition policy, health system strengthening and transformation, and universal health coverage. In particular, donor dialogue on and donor support to public financial management is crucial to promote efficiencies, value for money, and risk management. For the health and nutrition sectors, I think was mentioned by our colleague from Niger, strong and efficient public procurement systems are particularly important. If a procurement system has systemic problems, increased funding in the end will not really matter. At APIC's donor government dialogue tables, as are present in most countries, engagement on medium-term expenditure frameworks, or where there is no empty medium-term expenditure framework, at least beginning the discussion to encourage the development of one, are in fact key to establishing multi-annual funding for health and nutrition and other services at the country level. Finally, we need to determine the means of measurement and accountability. Contributions towards the financial targets that we need to set need to be visible, including both domestic resource allocation and international contributions. The Global Nutrition Report can be leveraged to provide an annual update on this, with commitments and gaps tracked to keep stakeholders accountable. For Ireland, we're absolutely agree that targets need to be visible. Ireland is a strong supporter of the new nutrition policy marker, and we are committed to using the policy marker in all our reporting. I'd like to conclude just with two last slides, if I may, if you want the next slide, Gillian. I know there was a briefing around today's session around building resilient systems and resilient health systems in particular. So I thought I would just throw up, just to encourage discussion in the future perhaps, or to remind us of resilience framing and resilience frameworks. And I think this framework, most colleagues perhaps on the call are quite familiar with it. But I put it up really just to remind us about the complexity of building resilience at different levels, that at building capacities at absorptive level, at adaptive level, and at transformative capacity and transformative levels. And indeed trying to build all of those capacities across a range of levels from household, community, institutional, and national. So in this discussion, I think, which is an important discussion about building resilient systems, in particular building resilient health systems, it's important to interrogate this framework. It's not the only framework. To think through where we are working as an organization, where we're working as an international community across this system, like a particular lens. If you could just put up the last slide, please. And just as an example, from Ethiopia's Social Protection Programme, which Ireland has been a long-time supporter of, notwithstanding the current trials in Ethiopia, the Ethiopia Productive Safety Net Programme is ongoing, and the PSNP programme is internationally recognised as quite an exemplar of its type. But this is a mapping exercise which we carried out in the Addis Ababa Embassy while I was in the mission there, trying to actually map out how the PSNP programme, which contributes to nutritional outcomes at household level and community level, how it was mapped, how it was performing against the resilience framework. And we use this, if you like, as a tool for dialogue, both around the donor table and with government, to help us improve our dialogue and to talk about how we can improve the system going forward. So it's just an example. This could be done also easily for the health system as well, try to help interrogate where we are in building our resilient systems going forward. So I think with that, I'll pause and just end, happy to take any questions as they arise. Thank you very much.
Thank you, Patrick. And thanks particularly for that second to last slide, just reminding us of the resilience framework, because I think it's extremely apt when we're talking about resilience of health systems. I think all of those concepts are really appropriate and can help us think through how to build more resilient health systems. We are just about out of time, so I think we are going to just end here. There's been just one question in the chat. There actually weren't very many submitted before, but there is one question about treatment of managing wasting among children under 6 months. I'm not sure if we have time for a response, but I just wanted to raise it here. Just what is the plan for scaling up MAMI into this health system strengthening program? And sorry, that's my camp. Since the management of acute malnutrition in infants, sorry, I know I'm getting that acronym wrong on the spot. That's the old acronym, but basically just how are we going to incorporate children under 6 months into these plans to scale up nutrition within health systems. I think it's an important point, but as I said, we're just at 12. The presentations were so comprehensive that I think a lot of the questions that we had generated to ask you were very much answered. So I think I'll just end by saying a huge thank you to all of the presenters for excellent presentations, for the participants for sticking with us. And I hope to see you all at the remaining side events for the Nutrition for Growth, and hopefully engaging in the summit itself. So thank you, Amina, Barbara, Helena, Madhu, and Patrick. And we'll see you soon. Take care, everybody.
Thank you. Bye. Bye.
Thank you.
Bye-bye.